Oh, welcome. Good morning, Harshad.
Good morning, John. How are you?
Good. How are you in India? In Mumbai?
India is very hot,
Really?
very hot and humid. And
Oh, okay. Because we
you
we
are
get hot.
you are
So this
lucky to
time,
be in a good weather.
oh yeah, we're not hot here yet. It gets hot here around June and July.
Hmm,
That's August. Those
very
are
hot here.
just
What time it is now there?
4 o'clock.
Oh,
Uh,
you are still awake.
yeah, yeah.
Oh, wow. When
Uh,
do you
cra-
sleep?
Crazy hours. No, I slept earlier in the night. You know how it goes. You just kind of make do with the schedule and stuff like that.
It seems I to see you always awake.
Not always, no, no.
Hmm,
It's like working on call.
hmm,
You just get your sleep when you can. And
hmm.
sometimes, most of the time, you don't get your needed sleep.
Hmm,
But,
hmm.
but that's the way medicine is. People accept that.
Yeah. No, no, great, great. I to always see you always awake.
Yeah, you got yeah, we haven't been having too many conferences
Yeah,
because
too many.
now I'm trying to establish a model where the
Hmm.
drug companies pay for the webcasts.
Yeah, sure.
Because the way it is now, people like me that do it for
Hmm.
free, but there are not
Yeah.
many people around like me.
Mm-hmm.
Most universities, they take care of their own,
Right,
obviously,
right.
obviously, and they're not interested in funding
Yeah.
global webcasts. But
Uh,
maybe we'll change that feeling. So
mm-hmm.
I'll be back.
Yeah,
Yeah,
yeah.
yeah, yeah.
Okay.
Are you at home? Are you at home now?
No, I'm still working, but I'll be in touch. No problem. Yeah.
Okay, I'll be back.
Yeah. Okay. Yeah. Bye.
Hi, Raja, are you there?
Yeah,
How
yes,
you
Dr. Bennett.
doing? Yeah, hi, do you have your camera on, please?
Yeah.
You don't have to put it on now, but how you doing? Hi, nice to meet you.
Yeah, hi, Mr. John. Yeah,
Okay, we're not on the air yet, so, basically, you don't do anything. At the end of the webcast, okay, then I introduce, then I say, okay, the webinar is over. However, we have a word from our sponsor.
yes.
And Raja, I'll introduce you, and then you basically introduce yourself and say what you want and do the demo. You're gonna do the demo today?
Yeah, we have a video to play.
Yeah, okay, just go to the video. We'll keep it real simple, real short. And
Okay.
I want you to get used to doing it and getting comfortable.
Yeah,
So after you, I'll be there. And other neurosurgeons will be there. Usually everybody stays. It's really nice. And you may get a question or two, but maybe not. And that's it. Just like 5-10 minutes. That's all. And so, and you, I know you may not like the presentations. You could just come back if you want. You can do what you want. But it's at the
the
end. It's at the end that I need you.
how long the meeting will be go?
I think we have a lot of talks. So let me share the screen now. So I know that for some people, it's not too interesting subject matter. So I don't expect you to, I know my brothers don't like to stay at all. Okay, you can make a judge of this. Okay, 11 a.m. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 talks. I would say between 2 and 3 hours.
Yeah, okay. It takes around 2 to 3 hours, right?
Yeah, that's when you need to be here, in about 2 or 3 hours for sure.
Sure, Mr. John. In the meantime, I will text you from my WhatsApp number.
Yeah, you can. I'm responsive to what's up, so you can check with me almost how many more
Yeah,
speakers, whatever. It's
yeah.
hard
If
for
you
me to
want,
say exactly. You
if
can
you
just
need my
stay.
presence,
You can
yeah, yeah,
stay
yeah.
in the. You can stay in the panel and mute it and
Okay,
do your work, and you know what I mean. Take a picture off. Put your audio. Maybe leave your audio on if you want, and then do your
got it,
work.
got it, right.
Until it's over, and I'll check with you. I'll say, Raji, you ready? We're going to be in 5 minutes. Okay.
Yeah, got it, Mr. John.
Now, do you have much experience do you like internet? You like doing webcasts and stuff?
Sorry?
You like doing webcasts? Have you done much Zoom?
No, give us some time. My audio is not that much good. Just
Oh,
a
okay.
second. Just a second. I will connect my Bluetooth.
Okay. I've got to go. Okay. But I'll see you. Does anybody have a word? I think we're waiting for Ipe. Now, I hope, now the people that are giving talks, you need to come in the panel. Okay? Because I know there's some people in the panel here that are giving talks. And they should be in the panel because they're going to be presenting from the front of the room or from the computer, whatever. Uh, if you, I need to promote some people, so just raise your hand. Okay? Hello? Anybody in the panel going to present? Does anybody need to come in from the panel? We're still waiting for Hey, Ike, you ready to start?
John, buddy, I am starting at 3:30.
Well, who's gonna introduce the speakers? Is there someone over there that's gonna introduce the speakers?
Keith has told nothing about that, but I'll be starting by 3:30. That's what he told me.
Okay. Okay, so who's running the webcast? I don't know any of the speakers.
You know me, man, so that's enough. They
Okay,
introduce me.
okay, let me search for someone. Maybe I'll just ask them. Okay, Ike, we'll
Yeah,
see
sure.
you when you're ready to come in.
Sure.
Okay. Okay. We're flying by the seat of our pants now. We're not live yet. Now we need a moderator, okay? Because I don't know any of the speakers. So Dr. Jones doesn't seem to be here. Okay, let me check on the panelists. Okay, there's nobody in the panel. Who's going to run the show from Zambia? Let me check on what's up. Where is the, okay. Where are the speakers? Okay, I need to speak to the, well, hello, is anybody listening to me? Okay, Jones. Wow. Okay, any panelists that are speaking? Okay, I need someone in the waiting room that's supposed to be speaking. We're waiting for local Zambian people to step up. Of course, if you're not, you don't have to come in. Okay, still waiting. Uh, Hello? Man, what is going on? Uh, Okay, we're waiting for the speakers to step up. Okay, okay. Okay, are there any speakers from Zambia in the panel? Something is wrong here. I'm losing contact with Zambia. Not answering. Oh, we spent some time getting this together and everything. Okay, we'll try to get it together. I used the right link to get in. Okay, stay here. I'm looking. I'm trying to get contact with Zambia. They could have maybe some problems there. I don't know, internet problems. Because it seems strange. Okay. Hang on, there's no news. I've had surgery, but Dr. Jones, O'Keefe. And I'm gonna try to share. Okay, tell me if Dr. Katambo, Dr. Monig, Sufinov. Are you seeing the share? Are you seeing the share? Hello? Hello? Morning. Still checking, folks. Hang in there. This is a complete collapse. I'm not getting any response from Zambia, which leads me to believe there's an internet problem, unfortunately, because no one is answering. Dr. Jones, Dr. Morba. Okay, hang in there, folks. I don't see any of the speakers in the panel, and you saw the speakers yourself. So there may be we're investigating now to see if there's an internet problem in Zambia. So give us a few minutes, okay? hang in there. We may have to postpone. Oh, Dr. Sufinov's here. Oh, okay. Great. You can start. Okay. Okay, Dr. Sufinov, let me let you in. I see you, Dr. Sufinov. I'm getting you in. Does anybody else want to be led in the panel? Okay, Dr. Sufinov, I let you in there. Are you there now? Can you hear me, Dr. Sufinov? All right, Dr. Sufinov, are you ready to start? Hello, Dr. Sufinov? Hi. How you
Hello,
doing,
hello.
man? I'm glad you're
Hello,
here.
John. How are you?
Good, good. Okay, are you ready to start?
Yeah, no problem. If necessary, we will start.
Yeah, okay. Okay, here we go. Let me get off this here. Well, hold on, okay. Okay, here we go. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, it's Dr. John Bennett broadcasting from the home of Neurosurgical TV. We have the pleasure of having our ZAMBIA conference, a two-day affair. We're starting off with Alfred Sufianov. Dr. Sufianov is from Taiwan. He heads the Federal Center of Neurosurgery. He's been very active in social media. He's trained all over the world, including Japan. He has some great stories about that. And we're glad to see him here. Good morning, Albert.
Yeah, good morning. Good morning, John. Good morning, everybody. I am ready.
Okay, ready to go.
Okay, okay.
Perfect.
Possible to say. Okay, okay. Good morning for everybody. Good morning, Zambian neurosurgeons, and especially good morning for Kate, who was with us some years and have a lot of experience from our Federal Center of Neurosurgery. So today I want to introduce our experience about really challenge part of current neurosurgery about schwannoma surgical treatment. and especially of treatment of the giant vestibular schwannoma. Giant vestibular schwannoma. Sorry. I am especially for the Zambian neurosurgeon, I am chief of Federal Center of Neurosurgery, and our center was staying in Tyumen city in the Russia, just in the middle point of the Russia, you see? And this is our center of neurosurgery. This is a special center only for neurosurgery, and we have very good equipment and a lot of cases. For example, our center is only for elective cases, no emergency, and near the more than 70,000 neurosurgical cases and more than 5,000 neurosurgical cases per year we do. And we have 5 neurosurgical departments, and we cover all the field of current neurosurgery. And 7 operation room we have, including 3D hybrid ICT operation room. And you see in this slide our equipment, for example. You see our hybrid.
Hello?
Okay.
John?
Yes,
Hi, John. So Professor Ip Sharon will go first.
okay, he's not, who is this?
Okay, it's possible to continue.
Hello?
Hello?
Yes, we
Possible
we need someone to be in the panel. Where are the speakers? Where are the panelists?
Hello, we're connecting to you now, right now.
Okay, okay, Sufianov's going, and we have to get a speaker next.
Okay, possible to continue. John, possible to continue. Okay, this is our ICT operation room, and this room is very useful for challenge cases in neurosurgery. You see CT on the rails during the operation. It's possible to use like this. During surgery, before the close of the wound, it's possible to check all situation inside of the brain on the skull. Go by rails. This is ICT operation room in our center. Also, we have a lot of modern equipment. This equipment is very useful in this challenge and this difficult surgery, like the giant vestibular schwannoma, CP angle surgery, for example. New possibility give us the thulium laser, like this, you see on the slide. And also now we widely use in this kind of surgery 3D exoscope. 3D exoscope, you see, we have two type of exoscope. One is from Storz, one is from Esculap. So this is robotized arm from Esculap, 3D exoscope, and 3D picture is very useful for this kind of surgery. You see our operation room. So a lot of monitors. All monitors is a 3D endoscopic tools, and so also. And you see this is 3D exoscope. And this is the position of the surgeon with a glass, special 3D glass. For this kind of surgery, it's very important to understand anatomy of the skull, and the surgeon must know very well the all landmarks, even on the skull's bone surface. You see on this slide, you must understand where is the roof zygoma, parietal mastoid sutures, lambdoid sutures, asterion, occipital mastoid sutures, and so on, digastric, mastoid, teeth of mastoid, condyle, and so on, just to perform access to the CP angle. This is, you see, more close this area. Again, the mastoid region, digastric roof, asterion, and a lot of shooters around the mastoid. And this always landmarks is very important just to create the access. Uvula tuberculum. And again, this is a giant vestibular schwannoma, and sometimes you need to open the more bony So why you must have experience and must understand muscle anatomy in this region just to good dissection. So why you must know 3 layers of this in this region. And first layer is the supply layer with the sternocleidomastoid muscle, splenius capitis muscle, and the trapezius muscle is the first layer. Second or middle layer is the longissimus capitis muscle and the semispinalis muscle, and the third deep layer with rectus capitis posterior major minor and superior inferior oblique muscles. Very important just to know not only muscles, but also very important to know the point of fixation of the muscles, because it's very important for good dissection. So why you see in this slide, you see the third layer, second layer, third layer, deep layer, for example, the point of fixation. In this slide, I see the deep layer, the trigonum created by the rectus capitis majors and obliques superior and inferior. And why is so important? Because under this triangle, you see the big, one of the most important vertebral artery just lie. And for safe dissection of this vertebral artery, you must dissect this triangle. And now, why we use translap approach? Which is advantage of the translap approach? As you see in this slide, this is a retrosigmoid approach, and this is translap approach. The one of the most important advantages is completely absent of or minimally brain traction. You see the brain traction, big brain traction when you use retrosigmoid approach like this, and you see the direction of the translap approach completely absent of the brain traction. So no damage of the brain by it. The full visual and neurophysiological control of fascial nerve integrity, prevention of the caudal nervous injury, and comfortable plane for the surgical dissection, especially for the brainstem. You see the in this slide. This is the position what we use in this kind of surgery. And one of the most important things is the neuromonitoring. You see the patient prepare for neuromonitoring. The auditory brainstem response, direct facial nerve stimulator, EMG, map, and so on is very useful in this kind of surgery. This is the head position and the external mark skin incision. You see the skin incision line before the ear. This is the mandibular angle. This is the mastoid tip. This is one of the most important, the landmark on the skin. It's possible to palpate before the surgery, before you open the skin. And now we step by step, I try to show the translap approach. So you see the dissection area, you see the asterion. I show you before the very important to know the bone landmark just to create a good right approach through the bone. This is the mastoid. Mastoid is mastoid tip, and this is the triangle approach. Mastoid triangle. So sometimes it's very necessary to save the occipital artery. This is occipital arteries, and sometimes also very necessary to keep safe this artery. If something happened during the surgery, it's possible to create some bypass anastomosis, just to save for a patient's life. And now another step is surgeon must expose sigmoid sinus and facial nerve and middle ear. And you see we drill. This is sigmoid sinus. This is temporal lobe. Now we start to open middle ear here. I prefer use cutting bore. This is antrum, middle ear, and you see the incus here inside. This is a very good landmark for the middle ear, incus. Now we more and more open the sinus, sigmoid sinus, you see very well. Sinodural angle open after the open the temporal middle fossa dura and the sigmoid sinus. Between is sinodural angle. And now we start to open facial nerve. It's very useful monitoring. You see, I use a monitoring probe just to localize. You see very well the facial nerve here now. Temporal lobe, sigmoid sinus, facial nerve, middle ear. You see now it's very well open the fallopian canal. After we start to open semicircular canals. You see well facial nerve, and now I open the posterior semicircular canal. You see like this. You see sigmoid sinus, the temporal lobe dura. Next one is the lateral semicircular canal. You see here very well anatomy. And now we open superior semicircular canal. Good landmark is subarachnoid artery. This one. It means what you open semicircular, superior semicircular canal. You open this canal just to open the internal meatus. You see very well. Lateral, posterior, superior, facial nerve, middle ear, incus. Now we just start to explore the internal auditory canal. And you see the projection, facial nerve, superior and inferior vestibular nerves. It's possible to open the canal 180, more than 200 grados. It depends from the situation, clinical situation. After you open the dura and just start to tumor removal, you see the sinodural angle, sigmoid sinus, facial nerve, and this is the dura. That's the parallel to the superior petrosal sinus. But sometimes it's necessary to open also the sigmoid superior sinus and cut the dura more and tentorium more, even complete cutting. And now you see the tumor, and we start to debulking the tumor and remove the tumor. You see the monitoring of the facial nerve very well, saving. And now this is our result. We have 12 years of experience of vestibular neurosurgery here in Federal Center of Neurosurgery, and more than 600 cases we have experience. And in these cases, 33 cases of giant vestibular schwannoma surgery we use by using the translap approach. This is age, size, period of hospitalization. And this is some examples. You see the patients before surgery. This is the MRI before, is a good one, good vestibular schwannoma, big compression of the brainstem, and this is total removal after operation by translap approach. This is the fat inside of the tumor's bed. And this is a video step by step. Again, open the bone, dissect the muscles, save the occipital artery, dissect it, and keep saving the occipital artery. Again, dissect vertebral artery. This is C1 because it's a very giant schwannoma, so I decide to open and remove the C1 and open the foramen magnum. This is the plexus of vertebral artery. And now I start to drill the mastoid triangle. This is mastoid triangle, and now I check the various facial nerve by the monitoring probe. And now I start to open sigmoid sinus more precisely. This is sinodural angle, open here. This is temporal lobe. This is here's projection of the middle ear. You see how I drill the parallel of the important structure. For example, in this area, parallel the sigmoid sinus. Again, check by monitoring, step by step. Now we open the fallopian canal. You see the very well facial nerve inside. Now I open the sinodural angle more widely. Again, this is sinodural angle, facial nerve, middle ear area, sigmoid sinus. And now I drill under the facial nerve, under the fallopian canal. Because I know now very well where is fallopian canal, so I drill very safely, widening access to for the tumor. Now I start to open the semicircular canal also. You see very well here, superior, lateral, posterior, posterior. This is lateral and superior semicircular canal. Now I start to open the internal acousticus canal. You see very well. Now it's open completely near the 200 grados. And very well monitor facial nerve by the probe, you see. And from the beginning, I know where is the facial nerve very well. And it gives me a big help for saving facial nerve in this challenge surgery. This is the tumor. Debulking. I start to debulking of the tumor. And dissect from the facial nerve, you see very well. From internal canal, you see very well facial nerves. Debulking piece by piece, I remove the tumor. Debulking. Safe arachnoid membrane is very important for safe facial nerve. You see facial nerve very well. You see the safe arachnoid membrane. Important step, you see here. This is after tumor removal. Total tumor removal with good dissection from the brainstem. You see the facial nerve after operation, it's safe. Another case, again, giant vestibular schwannoma, it's before surgery. Tumor, total removing of the tumor. This is the fat inside, translap approach here. This is our 3D technologies for the preoperative planning. It's very important for understanding anatomy, for example. So why surgeons must create before the surgery with computers 3D imaging, just to understand approach, anatomy, how drilling, the bulb, sigmoid sinus, main vessels, and so on. We use for this kind of surgery in a BTech program, for this kind of planning. It's possible also modeled approach virtually before surgery. Sigmoid sinus very well. Bulb, jugular bulb, tumor, incipient angle. internal acousticus canal, you see. Very good for understanding before surgery. It's very important step now. Possible to show also the brains and relations between the neurovascular, very important neurovascular structures and tumor. Now the case, after planning, we go to the surgery. You see the skin incision behind the ear. And this surgery I performed by 3D exoscope. It's not by microscope. You see the very wide picture, very good quality of the picture. So this is in 3D surgery by exoscope, not by microscope. The quality of the image is brilliant and in 3D for all operation team. You see the mastoid process. Just now we start to drill the mastoid triangle. You see very well, sigmoid sinus. And now I start to open the middle ear. Also in this kind of surgery, sometimes I prefer the match head bore for very precise drilling. You see the middle ear. We start to open the middle ear. And a lot of irrigation is necessary for safe drilling. Now start to open not only sigmoid sinus, also the bulb. This is the posterior fossa tumor, sigmoid sinus, transverse sinus. This is facial nerve projection. And you see very well now, fallopian canal is open now. We check by neuromonitoring. And now I continue to open the jugular bulb. Also check the situation by neuronavigation intraoperatively. This is the neuronavigation probe. And then I start to open the semicircular canals. This is the posterior semicircular canals. This is the lateral semicircular canals, and this is the superior semicircular canals here. You see very well anatomy: jugular bulb, sigmoid sinus, posterior, lateral, superior semicircular canal, synodural angle, temporal lobe. And now we start to open internal auditory canal. You see very well. You see very well, and after opening the internal auditory canal, I just open the dura, of this region. You see, I open the dura above the cerebellum and above the internal auditory canal, and now you see very well the tumor inside under the dura. And now we very well dissect the tumor from the facial nerve. You see this is the facial nerve very well here. and this is a tumor. And this is a good plan for dissection between the tumor and for the facial nerve before the starting to remove the tumors. It's very important, just for saving facial nerve. And now standard steps, interdecompression of the true by the CUSA. CUSA or laser or something like that. For the inner decompression of the tumor, for good dissection for the future steps. It's very important, those steps. And then dissect the tumor from the surrounding very important structure, brainstem, facial nerve, vessels, the nerves of the CP angles, like 10, 11, 12, 9, and from brainstem. And like this, and totally removed of the tumor. This is after operation, also good function of the facial nerve. And how we teach my residents for this kind of role, because this kind of is very good for surgery, but need some learning curves. So why we have the Kate know very well about our lab. So we have a special 3D lab, and you see how our residents study this approach. And not only on the cadaver, first step is we use this special printing, 3D printings model. You see, this is models preparing for the courses of the drilling, for example. And this is our lab for the temporal bone drilling lab workshop. We have a lot of experienced neurosurgeons, very famous, like Luis Borba, for example, come for our lab and for teach our residents. So why? In this kind of approach, learning curve of surgeons is very important, especially must use the special lab for the training. This is cadaver lab, 11 places. So conclusion, Translab approach is the most optimal for removing large and giant tumors of the CP angle. But learning curves of surgeons is very important and need. So welcome to our place for our cadaver lab. We schedule activity, educational activity for next year. We open for the collaboration. Thank you very much.
Okay, very good. Thank you, Dr. Sufjanov, for taking the time this morning. And I'd like to ask the panels if they have any comments or questions. I know there are a couple of people that know you. Aldo, are you there? Aldo Spallone?
Yes, I'm here. And actually, rather than Spallone, which is pretty American, my name is Aldo Spallone. So
Okay.
don't forget, it's even difficult for me to make it clearly understand to Russians. They usually do the opposite. They call me Spallone Aldo Dariovic. Привет, дорогой Альберт. Я видел твою лекцию великолепно. Hello, my dear friend Albert Sufjanov. I saw his mastership on this video. I saw his mastership on the real time because I had the chance once to be in his place. It's really impressive. And I must say officially a big regret. I was appointed to the university where he's teaching before he came. If I quit it for several reasons, the quality of the training was very poor. And I'm very happy that this university finally called Sufjanov, because as far as I could understand from his way of presenting is very nice, not only surgical, but under the organization point of view work. This is a real guarantee that Russian neurosurgery, who suffered in the past from the fact that the training was not, let's say, equal to the training we organize in Europe and mostly in the US, now also thanks to his nice job, he can quickly approach even quality-wise. Although the result is very good, because myself, I'm testifying the goodness of Russian neurosurgery in general. Maybe the big caseload and the fine tradition help everybody who works in Russia to set up a very reasonably good level of neurosurgical job.
Thank you, Aldo. Thank you for your comment. Thank you. Thank you very much.
Thank you. Can you see me or no? No, you don't see me.
No, is your camera working okay?
I don't know. I had problems, and I have a nice student here who wants to be a neurosurgeon. Alberto, подумай, следующий раз позвони, отвечай моим звонкам. I have here a very nice student from, to say, a guaranteed family. His father also is a colleague close to our specialty, wants to be a neurosurgeon. He's a little confused. I'm trying to give him a nice direction, but once again, you cannot see me.
Okay. Okay, we'll have to wait till next time. Okay, more comments or questions from the audience? I noticed there was a neurosurgeon from Uzbekistan. Okay, very good. Okay, thank you very much, Dr. Sufinov. We're just going to hang out here because apparently this having some problems in Zambia with the internet. We're going to wait here for the next speaker.
John, thank you very much.
Thank you. Have a great day, Albert.
Okay, okay. Thank you. Big honor for us. Thank you very much.
Okay. Okay, Katembo. Okay, looks like there's someone coming in from, do we have the next speaker? Dr. Katembo? Let me see here.
Yes, can you hear me?
Yes, okay, we got you. Okay, great. What I'll do, thank you for coming. Are you all set up with your computer and everything? We don't see your face.
Yes, I am.
Yeah, don't see your face yet. You have to put it on. That's why they call it video cast. Can you get on?
Yes.
Okay. It's bottom left. You have to click on that icon on your Zoom.
Options. Okay, just a second.
Okay, it's okay. We're just glad you're here.
Thank you.
We're having a hard time getting a hold of everybody. But we'll get it done. Oh, okay.
How do we request for panelists or what?
Have you given me permission to share the screen?
Yeah.
Okay, okay.
Okay, we'll
So
forego the video. Go ahead, just screen share it. Go. Introduce yourself and screen share, please.
Dr. Bennett, we want to join as a panelist so we can screen
Okay.
share.
Yeah, okay. I believe he's in. Oh, okay, maybe that's the problem. Okay.
Yes, we have to join as a
Yeah.
panelist. Yeah.
Yeah, okay.
So we'll rejoin.
Yeah, I don't know what name are you using to come in?
Okay.
Give me a hint of the name you're using.
It's
Oh.
Samakai.
Okay.
Can you see it?
Oh, I think so. Yeah.
Yes, yes.
You got it? Kaumba?
Katambo, yeah.
Tolopu? Tolopu?
No, Katambo. Let me send you that. Send it.
Oh, have them raise their hand.
Okay. I'll
in
raise the
that
hand.
chat, yeah,
Yeah,
there we
just
go.
raise.
Okay, good. That's the way to do it. Okay, there we go.
So you join as a panelist. And
Yeah,
then,
that should be fine. Okay, you're coming in. You should be able to screen share. Okay, do you have it enabled, the screen share? I think you probably do. Yes, you do. Okay, full screen. At the bottom, there should be some options. Okay, okay, that's fine. That's fine. Just go ahead. Introduce yourself and away we go. Oh, I think this presentation's frozen. Can you hear me okay? I think,
Can you hear me?
yes.
Great.
Okay, you can
Okay.
start. You can start.
Great. Okay, so I'll just go back and introduce again myself. My name is
Okay.
Dr. Elijah Samakai Katambo. I'm a fourth year neurosurgery resident at the University Teaching Hospitals of Zambia. So we're going to talk about the temporal bone anatomy, applied anatomy. This would be an important introduction into our conference on the skull base. So I'll go straight into it. So the objective this morning, firstly, would be to define, describe, and illustrate the anatomy of the temporal bone in general, and then thereafter to examine approaches to the temporal bone. So the temporal bone is one of the rather bones of the skull base. And of note is that, as you can see in this illustration, this is the temporal bone on both sides. The temporal bone has got four main parts. It's got a flatter squamous part, which you can see here. And then we've got a petrous part. We've got a petrous part. And then we also have a tympanic part. And then we have a mastoid part. So in addition to that, we also have an attachment from the medial end of the mastoid, which is the styloid process. Yeah. So again, like I mentioned, that in general, the temporal bone is divided into four main parts. We've got the squamous, we've got what would be known as the petromastoid part, which is divided into the petrous part of the temporal bone, the mastoid temporal bone, and then we have the tympanic part and the styloid. The squamous part of the temporal bone is the thinnest part of the calvarium, and as you may be aware, and further on,
Excuse me, Elia, the slides are not moving. Thank you for alerting me.
oh, thank you.
Mashor, yeah.
You see the next slide of the introduction?
Yeah, you're not, the slides are not moving.
Okay, just a second. Let me try to share it again.
You okay?
Can you see now?
Yes, I can see the introduction.
Okay. If I move one slide back, are you able to see?
You're not, I see the introduction. Okay, yes, we're seeing the bones, yeah,
See the bones?
yeah.
You can see the introduction,
I see objectives.
objectives, and the
Okay,
face.
yes.
All right. Okay, so we go right back to the introduction. We're saying that the temporal bone is divided into four main parts. We've got the squamous part, petromastoid part, the tympanic part, and the styloid process, with the squamous part of the temporal bone being the thinnest and has on its superior aspect a shallow groove known as the mandibular fossa, which the mandibular fossa is actually on the posterior aspect of the styloid, or rather the zygomatic process of the temporal bone. So this is where you find the temporomandibular joint. And you notice in my slides, I've used mostly abbreviations, with common abbreviations, which I'm going to expand into. So the petromastoid part of the temporal bone is composed of a compact bone, and is what basically contains the auditory apparatus. And the mastoid part of the temporal bone is part of the temporal bone that is trabecular and has got air cells in it, and contains an important part of the mastoid known as the mastoid antrum, which will go into further detail. The next part of the temporal bone is the tympanic part. The tympanic part, which is on the medial end of the squamous part of the temporal bone, and the styloid process, which, as you can see on this image, the styloid process is this protrusion that is coming, pointing down in that orientation there, where you find attachment to a number of muscles that we're going to mention later on. Okay. Are you able to see the next slide?
Yes, XR anatomy.
Okay, thank you. So this is basically showing the squamous part of the temporal bone in 3 dimensions, as you can see in green. And it's composed of the thin surface and the zygomatic process. And then on the medial end, you could see this in green rather, you can see this zygomatic process that is extending, joining with the zygomatic part of the temporal of the zygomatic process. So on the medial end, you could see the petrous part in green. And then inferiorly, you could see the mastoid part as well. On the undersurface, as you could see a number of structures that are zooming in. You could see the styloid process. Then you could see on the undersurface, the entrance of the internal carotid. You could see the jugular fossa. On the medial aspect of the styloid process, you could see the styloid process itself. Again, zooming in further, you could see on the lateral aspect of the styloid process, you got a stylomastoid foramen, which is the extension nerve. Again, here we see in green, this is the mastoid process. And behind the mastoid process, we find what is known as a mastoid notch. And as you can see, also posteriorly to that is a mastoid foramen. Okay. I'm going to proceed. Okay, so like we earlier mentioned, in terms of the parts of the temporal bone, the squamous part is the most anterior superior aspect of the temporal bone, and has got a thin, basically thin aspect that act on the lateral surface of the middle cranial fossa, and extends all the way into the tympanic aspect of the temporal bone. So this is an image just to show us the various views of the temporal bone. As you can see here, we are basically seeing the temporal bone from the top view. So the first part here you could see. So we have a top view on C, and here we have a bottom view. So on the bottom view, you can see here the zygomatic process of the temporal bone, and as it comes posteriorly, it forms two parts, two processes. It's got an anterior process and a posterior process, which encase what is known as the mandibular fossa. So in the mandibular fossa is where you find the temporal mandibular joint. On the posterior end, you could appreciate here the mastoid part of the temporal bone. And then on the medial aspect, you have the stylomastoid foramen here. This is where you have the exit for the facial nerve. Medial to this, we can see the jugular fossa. And then again, on the medial aspect, more to the petrous part of the temporal bone, you can see the carotid canal. This is where you have the entrance of the carotid, internal carotid artery. On C, we have the superior aspect. We're basically seeing the temporal bone from the top view. This is this line here you can see here is the squamous part of the temporal bone, which is a little bit darkened, this region. On the lateral end here, you could appreciate the zygomatic process, which has got an anterior root and a posterior root. And then in between this, on the undersurface, that's where we found that mandibular fossa. And again, the mastoid part of the temporal bone would be appearing here on the posterior surface. So when you're looking at the temporal bone from above, as we begin to move more medially, we can appreciate a thin part of the temporal bone, which is on the tympanic part of the temporal bone known as the tegmen. So the tegmen is the thin part of the temporal bone, which is actually the roof of the tympanic cavity. And then on lateral to this, we find what is known as the arcuate eminence. And then lateral to the arcuate eminence, we basically have, as you can see here, a trigeminal impression. So the trigeminal impression here is where you have the Meckel's curve, where you have the trigeminal ganglion lying right here. So again, this first segment, we're basically just focusing on the squamous part of the temporal bone. However, we wanted to just appreciate the relations that on the anterolateral aspect, we have a projection for the zygomatic process. And on the medial aspect, we find the tympanic part of the temporal bone. On the posterior aspect, we find the mastoid part of the temporal bone. And as you go more medially, we have the petrous aspect of the temporal bone. So this petrous aspect of the temporal bone in this image, you may not appreciate clearly, but you find an impression here that is protruding, a sharp projection, which is the petrous apex of the temporal bone. Okay. So I think I've already mentioned most of the parts. The next part I wanted to talk about is the zygomatic part of the temporal bone, I think, which I've already alluded to, that basically it comes from anterior to posterior, forms two roots, the anterior root and the posterior root. So the anterior root, we said, again, as I show you here, the anterior root is here and the posterior root is here. So when you flip the temporal bone again to see the undersurface, you can see that the roots are actually here. So here we would have the anterior root and the posterior root. And in between you have the mandibular fossa. Okay, so the zygomatic part of the temporal bone basically is what goes on to attach to the zygomatic bone, forming the zygomatic arc. Okay, so I'm going to move further. The mandibular fossa, like I already mentioned, has a number of features. Mainly, we're talking about an articulation for the temporomandibular joint. So this area is lined by fibrous cartilage. So because of the temporomandibular joint, which it is actually a synovial joint. Okay, so moving further down, we just a little bit going back to my images. Sorry, I'll have to go back a little bit more to my images. We see that on the inferior aspect again, as you can see, the zygomatic process coming to the posterior here. And then we have the styloid process here. On this lateral end, we find just posterior to the mandibular fossa, we find the external auditory canal. Okay. So at this point, I'm going to I'm going to borrow a 3D rendering of that I found very useful, that I wish to share in a moment. Okay. Okay. Can you see the screen?
Yeah, you're not screen sharing yet.
All right, thank you. So I'm going to use this. Can you see the image, the 3D model?
No, you're not screen sharing.
Okay. Okay, let me just reshare.
Yeah.
Thank you. Okay, can you see the screen?
It's getting there. There you go. Okay, we can see it.
All right, thanks. So what you're seeing here is, again, something that I found useful from the Neurosurgical Atlas by Cohen. So this, again, is a temporal bone. So I'm going to use this to describe the structures a little bit more in details.
Yeah, so the source is Neurosurgical Atlas by
Cohen, yes.
By Dr. Cohen, okay. Everyone knows who he is in neurosurgery.
Yes, yes, great. So as you can see, number one, the squamous part of the temporal bone, which we're already talking about, you can see how the zygomatic process comes from the lateral end and forming number one, the anterior root and the posterior root of the zygomatic process, in between which you find the mandibular fossa. And then on the posterior aspect, on the posterior to the mandibular fossa, you have the external auditory meatus. When I zoom in a little bit, you could appreciate some of the structures inside here. So already in this image is basically showing an osteology in 3D. So we don't see the tympanic membrane here. So you can definitely see some structures in the middle here. So going a little bit more posterior here, I would like us to appreciate a few structures. So firstly, we can see that there's a squamosal suture here that is running down as part of this squamosal suture is basically dividing the squamous part of the temporal bone from the petrous, what do you call this, the parietal bone, yes. So, and it's running down here, and from the point where it meets the junction here of the squamous part of the squamosal suture rather, and going more posteriorly, we have this suture here, the mastoid suture. We can appreciate that on the interior aspect, we find the root, the roof of the, or rather the point where the petrous part of the temporal bone actually goes to meet the squamous part of the temporal bone and forms this edge here, posterior to which you find the junction of the sigmoid sinus and the transverse sinus. So these are some of the landmarks that are very important when appreciating the anatomy on the lateral surface. When you're doing a bajo, for instance, you can literally estimate where you're going. On the posterior aspect again, we could see this suture here. Sorry, just let me just go back a bit. Okay. So at the point where the squamous part of the temporal bone meets the mastoid part of the temporal bone, we have a point known as the asterion. So the asterion is a point where we have 4 bones basically meeting. We have 4 sutures rather. We have the occipital, the lambdoid suture, the mastoid, occipitomastoid suture, and we've got the parietal mastoid sutures. These form the asterion. And at the asterion, if you did a bajo, you would emerge on the inferior edge of the junction of the So we could see that on the inner surface of the squamous part of the temporal bone, we could see that it's concave. It appears concave, and this is the impression of the temporal lobe as it sits on the middle cranial fossa. And as you can also appreciate that the squamous part of the temporal bone extends medially to go and attach to the greater wing of the sphenoid bone. So running through quickly, we go to the petrous part of the temporal bone. On the petrous part of the temporal bone, again, we can appreciate a number of things. So firstly, we want to divide it into the anterior aspect, posterior aspect. So the anterior aspect of the petrous part of the temporal bone is basically the posterior wall of the medial cranial fossa. And on the posterior side would be the anterior wall of the middle cranial fossa. So quickly to appreciate some of the most important parts of the temporal bone, the petrous is just like we had the external auditory canal. On the other end, on the lateral end, in the medial end, we have the internal acoustic meatus. So the internal acoustic meatus is actually a point where, or rather an orifice where you have structures, neurovascular structures that are coming from the brainstem going into the temporal bone. And these include the vestibulocochlear nerve, the facial nerve, as well as some blood vessels such as the labyrinthine artery, which is a branch, though it's not shown here, but it's actually the branch of the ICA. which also goes into the internal acoustic meatus. So the petrospat, again, on the medial end, though not indicated here, but on the medial end, it actually attaches to the occipital part of the clivus, rather, which is the occipital part of the occipital bone. So the junction between the petrous part of the temporal bone and the occipital bone is known as the petroclival fissure. Why is it important? Because this is where you find some structures that are passing through from the posterior fossa going through into the middle cranial fossa. Again, some of the structures that you appreciate in blue here is how the sigmoid sinus is coming in as an impression on the, as I move to the mastoid part of the temporal bone. On the mastoid part of the temporal bone, you could appreciate here on the inner surface how the sigmoid sinus is running from the transverse sinus to the sigmoid sinus and then draining through the jugular foramen as the internal jugular vein. On the superior aspect, you could see on the petrous part of the temporal bone, on the apex, you could see an impression here. This impression is the superior petrosa sinus, which will join the junction of the sigmoid sinus and then drain into the internal jugular vein. So in general, just to summarize, know that time is moving, but we have limited time. Another thing to appreciate on the undersurface here is you can see how, while the jugular foramen is on the posterior aspect, anteromedial to it, you find the carotid canal, and this carotid canal is where actually the internal carotid artery is actually entering into the petrous part of the temporal bone. Okay, so these are some of the basic structures that I wanted to show you using this 3D image. Yeah, so the temporal bone is again a very complicated structure, and I wish we could expand a little bit deeper into it. However, it's an important structure for us to appreciate because some of the neurovascular structures within the temporal bone are so much tight and cramped within the temporal bone that any small deviation in millimeters would have significant consequences. Okay. So I'm going to go back to in general. So this is a temporal bone. I don't know if we have any questions at this point before I conclude.
Any comments or questions from the panelists? Okay, continue.
We want to talk about some of the approaches in terms of understanding some of the approaches of the middle cranial fossa and the posterior fossa through the temporal bone. The anatomy of the temporal bone must be understood in depth, in its detail. So I'm going to go back to my slides. I hope you can see my slides. Can you see my screen?
Yes.
Okay, thank you. Okay, so some of the approaches that are used, the temporal bone, through the temporal bone can be divided into anterior approaches, the anterolateral approaches, the lateral approaches. And of course, in this image, though not shown, but we could also have some far lateral approaches and approaches coming from the posterior aspect, such as the retrosigmoid. This image here is just showing us the surface of the skull, the skull base. We can see the anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. I hope. Okay, yeah, there we go. So again, the bones are color coded. So in yellow you can see the sphenoid bone, and in blue, light blue here you can see the occipital bone, and then you could see on the lateral aspect you could see the temporal bone. So to bring this home, again, like we earlier mentioned, this is the squamous portion of the temporal bone. This is the petrous part of the temporal bone. This is the petrous apex. And the point at which we say that there's a joining from the occipital bone to the petrous part of the temporal bone is called the at the level of the clivus is the petroclival fissure. So in this petroclival fissure, a number of structures pass. So for instance, if you had a brain tumor that is in this area, so these are some of the approaches that we talk about. So firstly, from the anterior approach, we could have a medial transsphenoidal approach, a medial transsphenoidal approach with lateralization of the internal carotid artery. We could have the transpterygoid approach. From the inferior aspect, we could have endoscopic approaches. From the lateral aspect, we could have the anterior, open anterior petrosectomy. We could also have an approach we know as the Kawasi's approach. We could also have on the lateral side, the translabyrinthine approach, transcochlear approach. And these are approaches that are basically passing through the labyrinth and the cochlea. And then we also have the approaches posteriorly, which we know as the retrosigmoid approach, where you'd be coming from the posterior cranial fossa into the CP angle, and then going further into the petroclival fissure. So this image is just an example of what I was trying to talk about in the different approaches. When you are looking at the surgical anatomy in this area, so you can see, for instance, a tumor here that is sitting here, and it's compressing on the vestibulocochlear nerve and also on the facial nerve. It is just right in the cerebellopontine angle, as you can see here. So you have here the translabyrinthine approach. So in the translabyrinthine approach, you have you're basically passing through the mastoid antrum, going into the middle ear, and then further going through the labyrinth into this part, the CP angle, in order to get the tumor. The next one is on the posterior aspect, would be the retrosigmoid approach rather. So the retrosigmoid approach we're saying is posterior to the sigmoid. And then you would have to retract the cerebellum more laterally so that you could access the tumor. Then we have various other middle cranial fossa approaches. And this is just another image. Now, here we want to appreciate some of the structures that are in the cerebellopontine angle, which are entering through the internal acoustic meatus, for instance. So as you can see here, we have, this is the internal acoustic meatus. And as you can see, we have the vestibulocochlear nerve entering through on the lateral aspect. And then we have the facial nerve and the nervus intermedius passing on the medial aspect. It is worth noting that just as a reminder that the internal acoustic meatus is divided into 4 quadrants. it has got a transverse cruise and a vertical cruise. The vertical cruise is known as Bill's bar. So Bill's bar is what separates the facial nerve medially from the vestibular nerve on the lateral aspect. And then the transverse is what separates the inferiorly, the cochlear nerve from the inferior vestibular nerve. So these are structures that are worth noting for the neurosurgeon, are very important. So as you can see here, some of the arteries that are running along with the vestibular, so rather with the nerves, are number one, the labyrinthine artery, which is a branch of the ICA. And then we also have what is known as the sub auricular artery as well, which passes through this area. Yeah. Again, these are structures that are worth important because most of these structures are cramped within the same place. So that's why the anatomy to the temporal bone is very, very important. You can see an impression here of the inner ear and how the structures are related. If you look at this image, we are looking at the temporal bone from the superior view. We can see the internal acoustic meatus as you go medially, and then you find the tympanic membrane, and then from there you go into the tympanic cavity. So the tympanic cavity is on the lateral side is bordered by the tympanic membrane. On the medial side is bordered by a wall, a thin wall known as a cochlear promontory. So in the cochlear promontory, within this area, that's where you find the vestibular apparatus and the semicircular canals on the medial side. And then on the posterior to the acoustic meatus, we have the air cells in the mastoid part of the temporal bone. The biggest air cell is the mastoid antrum. And the mastoid antrum is an important landmark for the neurosurgeon because this is what communicates with the tympanic cavity. And the mastoid antrum in the mastoid part of temporal bone communicates with the tympanic cavity through what is known as the adductus ad antrum. So this is how some of the structures are appreciated in this image that I'm displaying. Okay. So again, here this image is just an example of a stepwise example of a flap that we will do. For instance, in a retro-sigmoid approach, or if at all it was a translabyrinthine approach, you could see the patient is positioned in the supine with the head tilted away from the surgeon, the face tilted away from the surgeon at varying degrees, suitably 60 degrees. It depends with the approach you're using. So some of the barholes that are important in this region is number one, the point which I talked about here. The first barhole for the surgeon. Yes, so the first barhole here you would appreciate is from the anatomy that I talked about. This is at the junction of the squamosal suture and the suture that is extending from the parietal bone here. So when you do a barhole here, when you go on the inner surface, you're basically going to be on the superior edge of the junction of the sigmoid sinus and the transverse sinus. Another barhole that you could put is on the asterion. The barhole on the asterion, on the inner surface, you'd find yourself on the inferior edge of the junction. And then you basically, if you had a high-speed drill, you'd go all the way around, and this is how you would open. So as you open some of the structures, as you reflect the dura, you could see there are some of the important structures here. You could see the sigmoid sinus rather, inferiorly. You want to appreciate the otic capsule. The otic capsule is the bony component of the inner ear that contains the auditory apparatus. In between this, you want to appreciate a triangle. known as the Trotman's triangle, which is important for the neurosurgeon in this area. And some of the structures that you find after you do the craniotomy, number one, you could see how the nerves are coming from the posterior cranial fossa into the middle cranial fossa. You could see we have the lower cranial nerves, cranial nerve 10, 9, 8, 7, and also 3 is more superiorly here. So as you can see that 3, the cranial nerve 3 is passing more closer to the tentorial incisura. The cranial nerve 4 will be passing in a junction between the petrous part of the temporal bone and the clivus. So this canal is known as the Dorello's canal. So Dorello's canal is where the cranial nerve 4 passes. And then, as you can see, we have this cranial nerve 6, cranial nerve 5, where we talked about its impression on the Meckel's curve. And then we have cranial nerve 7 and 8, which are entering into the internal, which are entering the temporal bone through the internal acoustic meatus. Yeah. So basically, this is my presentation on advanced applied anatomy of the temporal bone for this skull-based session. Thank you very much. Any questions?
Yeah, Dr. Katamo, thank you very much for your time. We'll start with Ipe. Ipe, how you doing? Welcome, Ipe. Do you have any comments or questions? Ipe, you're muted. Ipe, you're muted. Right.
Yeah, so I was just watching some of the slides. See, we're going to do right now, we are doing an endoscopic transnasal approach to a pica aneurysm. I hope it's the first time that it has been done ever. I was just watching some of the slides that my ENT is going to be drilling off the clivus, and then we're going to go and clip the pica aneurysm. Yesterday we had a very interesting another case. There was a medial temporal lobe cavernoma, so we went with a very small 2 into 2 centimeter craniotomy. We went in and we stripped the cavernous sinus from the temporal lobe, and through that very small approach, we could take out the cavernoma. So it is, we have named it as the lateral suboccipital pretemporal pericavernous extradural approach to the mesial temporal lobe. So both of these we are going to publish very soon. As we talk, people are writing it up. I see my very good friend Albert also. And I would want to, I mean, the surgery is going on, so I would not want to have a long presentation. So just go ahead and talk about ultramicroneurosurgery in the 21st century. And
excuse me, let's just finish this one up and then we'll do yours, okay?
yeah, sure, man, sure.
Yeah, any more comments on Dr. Katamo's excellent presentation before we move to Ipe? No more comment. Okay, Ipe, it's all yours.
Done, buddy. So I'll just share my screen. So I'll not go into the entire presentation. I just want to go into a few things that I want to show.
You want to make it full screen, Ipe? There you go. Perfect.
Yeah, so this is our lab in the bottom corner, and upper right corner is our OT. So we have the AOS exoscope for the courses, where we, just like Albert has it, so we use it for we call it ultra microneurosurgery. So we are operating at zooms of over 70. Yesterday we did this lateral supraorbital pretemporal extradural transcavernous or pericavernous approach through this, and it was the exoscope that really helped with such a narrow corridor to the medial temporal lobe. This is one of the exoscopes that we have designed in India. It's because we have designed it first generation because most surgeons don't like to shift from the microscope directly into the exoscope. They're pretty comfortable with the magnetic locks and things. They're not comfortable with the robot. So this is a microscope, but this is like a microscope, but it is an exoscope. It's very similar. So the shift is easy for people. And it has a camera just as good as the AO's exoscope. And it projects into a 55-inch screen at magnifications of at 60 to 70 times with very crisp pictures. This is something that we've done with ZAMBIA company. That's exoscope, full exoscope. This is a endoscope holder, robotic endoscope holder. So you can see how it is. It has 7 degrees of freedom. It can hold your endoscope for cranial assist procedures along with the exoscope. It can hold it for it can hold for ventriculoscopy. It can hold for transnasal endoscopy. So the thing in ventriculoscopy, it comes from the opposite side, and in transnasal, it comes from the patient's head end. So both surgeons can stand and operate without any issues. So this is also in the market. Both of them are in the market right now. So these are things that we are doing. Now we're actually with another group from Netherlands where we are making robots for drilling and robots for holding the endoscopes. And the next generation exoscopes are also coming. So innovation is something that we are focusing on, high resolution and high magnification surgeries. Now, I'll show you a few cases where we looking at high magnification surgeries. This is a cavernous sinus meningioma. So you can see on T2 weighted, it's dark. That means it's a hard, and it's really enhancing, and it's encasing the entire carotid. So you can see how it is, and we are going for it now. So you can see, sorry. Yeah, so you can see how it is. Now that left side, this is the left side, and left side orbitomeningeal band is being cut. So once the left side orbitomeningeal band is cut, I'm into the space between the temporal lobe. This is exactly how we went to the temporal lobe yesterday. So we cut this band and we strip the temporal lobe of the cavernous sinus. And when you strip the temporal lobe of the cavernous sinus, what you get is the tumor. So the tumor had invaded the temporal lobe dura. So all that tumor is being removed. So all that tumor is being removed now. And if you look medially, that is the cavernous sinus. So that's V1 and V2 also you can see. Third and fourth are here. So that's V2, that's V1. The fourth nerve is here. The third nerve will be here. So every tumor lateral to the cavernous sinus is taken up. Now we're going to the tumor at the roof of the cavernous sinus. So for that, we are drilling off the clinoid process, and that's the third nerve. So once you release the third nerve dura, the anterior petroclinoidal ligament, and you can go up to the optic nerve, and then you're using a 0.75 millimeter drill to deroof the entire optic nerve and the clinoid process under very high zoom. You can see here literally the clinoid process is occupying half of your screen. So these are magnifications above 40. So we are advocating young neurosurgeons to learn ultra microneurosurgery. Not microneurosurgery was fantastic, but it's a thing of past now. So no more microneurosurgery. To go into ultra microneurosurgery, we are trying to develop scopes which can see, which can magnify good stereo depth into 100 and maybe even 200 times. So many things which are not possible with just microneurosurgery, like total internal decompression of tumors, where you can stay inside the tumor and decompress every bit of it without hurting any cranial nerves, instead of pulling and pushing, tumor capsules away from vital structures, producing small vessel injury and producing deficits. You can stay inside the tumor and take out every bit of it. So these are things that we will show you. So you can see third nerve, you can see the V1, you can see the V2, you can see the clinoid triangle. My fellows from South America has done these illustrations. And you can see now going inside the Parkinson's triangle and decompressing the tumor. So you can see the sixth nerve there. That's just medial to V1. And you are going to take the tumor away from there. The carotid turns there. You got to be careful about that. Now, the thing is, we are keeping on decompressing the tumor there. And this is after the tumor has been taken out. Patient did not develop any new neurological deficits. As people say that, you think that you do something in the cavernous sinus, you will have problems. It's not true. These are old dictums, so we are rewriting them. There's no more point holding on to the old dictums of just microneurosurgery. I want the young neurosurgeons to learn ultra microneurosurgery. Now, this is another case where this is an ST being anastomosed to an M4. And what I want you to see is the size of this ST. It's a 0.7 millimeter vessel. And what you're seeing right now is you can even see the vasa vasorum. That's the size at which. Now, I'll not spend too much time. I'm going to show you how we anastomose. Again, we have designed our own instrument set with the Omedic surgicals so that this at this magnification, you can anastomose without any hitch. So we, by trial and error, we developed this instruments which cost only maybe 1/10 of the instruments that we usually buy from big companies, but the quality is probably twice or thrice better, because most of the big companies' instruments are just designed to operate at 20 to 30 zoom at max, and here we have instruments which we can operate at 70 zoom. Only thing is we're trying to get a better needle. Now the 3 millimeter needle is not good enough for us. We need probably a 2 millimeter needle. We've been in talks with Johnson & Johnson and Vitilon sutures for this. I hope once they make that, then we can do very, very small anastomosis. with the exoscope and the instruments, it's possible. So we take about 5 sutures on each side and then 1 suture on the toe and the heel. And after we finish this, there's no leak. You can see 5 on one side, 1 on 1, 2, 1 heel, and about 12 sutures. Once you're done, no leak. And ICG confirms that. The ICG confirms that it's a beautifully filling anastomosis. Now the carotid is blocked off. This is a giant aneurysm where we had to trap the aneurysm. So once we've done that, that is the flow. Again, stressing on the importance of ultramicroneurosurgery. This is another aneurysm. So again, this is a duplication of A1. But what I want to see is the magnification. That's the optic nerve, and it's the vasa nervorum of the optic nerve. I'm sure you will not see this kind of magnification in many places. You will see it in Albert's place because Albert also has the EOS. And we did the world's first live surgical workshop in Tumen 3 or 4 months back in the winter. It was the world's first exoscope live surgery. We did an MC aneurysm. And this is how we dissect A1. And once we finish, that's the interhemispheric fissure. So here, if we have following that magnification and dissection, we really don't need to take out a lot of gyrus rectus, which is the teaching generally. We generally try to avoid that. Sometimes it becomes a bit difficult. In that case, we do it. But here, there's no need to take any gyrus rectus. So we are dissecting the aneurysm towards the dome. These are all ruptured aneurysms, every one of them. We don't get unruptured. So I'm sure in Africa also you don't get many unruptured aneurysms. In India, we are in a charitable hospital setup. We have about 200 beds for neurosurgery and state-of-the-art 3 operating rooms with all the facilities like exoscope, intraoperative CT, and whatever you would look for in the most modern center. And we have Professor Ramdas with us. We have Professor Selva Pandian, and also Professor Devabrata with us. So, and we have the Esculap Academy lab, where our fellows go and dissect regularly. We have fresh injected cadavers as well. This is another pike aneurysm. So we'd like to show you that as well. You know, the thing about pike aneurysms is that they are anterior to the cranial nerves. So you can see they are anterior to the cranial nerves. In a skull base, we figured that in any skull base, the dictum for the skull base approaches are that you should not cross cranial nerves. So since the pike aneurysms are anterior to the cranial nerves, we decided that we'll go for it from the endonasal approach, and this is what we are doing today. And it's been very clearly explained, and today I hope by midnight we'll be finishing it, and I hope things go well. And this is another pike aneurysm which we have operated from a far lateral midline suboccipital with far lateral extension. You can see this is the dissection, all done with the exoscope. Now, this was a bleb. The bleb has been dissected off, and now that's the aneurysm. The bleb is arising from the aneurysm. So, and that's aneurysm laterally. We're putting a clip on that. It's a brain stem there. I'm unhappy. There is a small strand there. I'm I'm not very happy with the clip. So we dissect again. We see the pica originating from the wood. And now we go ahead and clip it. Once I clip that aneurysm, the bleb is gone too. Yeah, that's a reconstruction of the pica, beautifully reconstructed. And so we would like to show you one more case where we are using the exoscope with the endoscope holder. So that's a exoscope view, very small craniotomy. I've taken this epidermoid, but on the other side of the forks, there's epidermoid sticking onto the pericallosal and the callosomarginal vessels. So I'm going there with the 3D endoscope. We have a 3D endoscope. This is called Einstein Vision. This is a 10 millimeter endoscope, but it's 3D. So it can be used beautifully for cranial assist procedures, just like you see 3D exoscope. It's also 3D endoscope. It's a 30-degree scope. It's quite thick, as you can see, and it's held in place by the robotic holder. So that you can see the pericallosal and the callosomarginal vessels. Now you will see how the setup is. It's a very small 2.5 to 3 centimeter craniotomy. So we advocate minimally invasive approaches. And that's my theater. That's an exoscope. And you can see the endoscope holder there. You will soon, this is the endoscope holder. This is the second generation endoscope holder. It's a Franca Amica. We are perfecting it. That's the Esculap's attachment to this. We work with Esculap to make this attachment for the endoscope. And we can use, this is a back drivable robot, very safe. And it's a cobot, so it doesn't, if it touches something, as you know, the ad is that if it touches a balloon with the pin, the balloon won't burst. That's how safe it is. So it touches anything, it'll stop. So one doesn't have to really worry about, you know, the robot tearing into structures and all that. It'll stop right there if you touch anything. Any resistance will stop. So this is another case which is large pilocytic astro right in front of the brainstem. You can see now the tractography, and we decided to go endonasal for this one. So that's a LOCRs, the lateral opticocarotid recesses. That's a sella, that's a clivus there. And this is the same approach we're going to use today as well. So we're going to do a clivectomy. That's a clivus drilling. We'll take the clivus, we'll do a maxillectomy, and after that we'll do a clivus drilling. And after that, once we take the clivus off, then we're going to open the dura. And once we open the dura, we use this right-angled bipolars to go in there. And that's the two vertebral arteries. The two vertebral arteries are like that, and that's a basilar. The basilar is completely displaced to one side. And that's a sixth nerve. So you will see the sixth nerve also very soon. Yeah, that's clival dura being bipolar, because the clival dura is very vascular. So those are the two vertebrals. And that's a sixth nerve released from its dural attachment there. That's the vertebral artery. That's a vertebral artery. That's a sixth nerve. My battery is low, so we need to kind of check. Can you put down the switch, please? And so that is a basilar perforator. That's the basilar. That's the sixth nerve. We're taking tumor out through these windows between the perforators of the basilar and between the sixth nerve and into the brainstem and a nasal route. So that window has been cleared. So that's a basilar perforator. That's a vertebral artery. That's a basilar artery. Sixth nerve is here. So you're taking out tumor. And that's a post-op. Patient is doing very well after 2.5 years. In fact, 3.5 years now. So she's doing very well. She came to us on a wheelchair, but no deficits as of now. Thank you very much. And I should say I'll stop sharing now. I will need to kind of go for the surgery. So God bless. And any comments or any questions, I'll be happy to answer.
Okay, you know, is valuable for the kids and okay, any comments? Go ahead. Go ahead.
Can you hear me?
Yes.
Hi, I was really impressed by your presentation, and you make me feel out of fashion, since this is the real innovation. I don't know whether you know something about my work, but I was at my time an innovator, and by the way, I had the privilege to give a lecture on traditional skull-based surgery. And actually, I must admit that the introduction of the exoscope, which I am very reluctant, I was very reluctant to be acquainted with. I was less reluctant with endoscopy. And it's making a real revolution of the technique, and I appreciate it tremendous your skill. But I have some questions. The first question is, how do you control your tremor, increasing 7-fold the usual way that we use the microscope? Obviously, the age has its own importance, but 70 per magnification is really extremely demanding. And I saw that your moves are quite well controlled. I can simply, if I would have to answer myself to my same question, would make a sort of comparison. There is a Russian neurosurgeon who used to be my pupil, and he admits it, and I'm very proud of it. He's the best neurosurgeon in Burdenko, no way. He invented a technique which is a compromise between traditional microsurgery and endoscopy. By fact, he does bar hole microsurgery, removing very big skull-based tumors, using, a trick which is very similar technically, strategically what you do. He invented a way to move the microscope with all freedom, so he can look in a very open position and to make a small hole and removing somehow the bone around the bar hole to make it a clean, lean bar hole, gives a way to have a very high angle of view. Then you must be acquainted with anatomy. I don't know why his technique didn't become very popular. Maybe because it needs to, as you do, you need some kind of commercial advertising. I do this, and because the basis of his technique is actually related to a special trick which is applied to any microscope, who gives total freedom of movements. And besides, the surgeon works with 2 hands, which is more or less what you do, which makes the big difference between traditional endoscopy, including skull-based endoscopy, and what you do, what he does. So my question is that what I noticed in see him doing surgery, try to understand that he's 10 years younger than me. He's over 60. I'm 72, even if I do my best not to look, but the passport gives full information, unfortunately. The fact that he works with a very limited entrance stabilizes its hands. So the small opening is a trick for traditional microsurgery technique to stabilize surgeon moves. It's like endoscopy. You have a very limited movement freedom, so you cannot tremor. Your tremor is not a problem. If I understood, you actually use a limited but not very limited opening. How can you control the tremor?
Yes. Yeah, so Aldo, excellent. I mean, I see that you're a fantastic surgeon, and that's why, I mean, your level of understanding of things are fantastic. So,
thank you.
I would ask you, where are you from? You from Italy?
I'm from Italy, but I work in Russia. Let's say as the Latin used to say, "Nemo profeta in patria." I had lots of problems in my career in Italy, and then I accepted a strange job in Russia. It was a scientific attaché of the embassy for a couple of years. Then I tried to settle here. It's not very easy. Russians, you know, nobody is happy to share the torch. And I understand that. I actually enjoying it. My basic job is to lead in a group which does experimental work. Very, very, very nice, and I'm very happy. I'm very unhappy that I had to miss a recent speech on spinal cord injury. We do a very updating, very prospective and perspective work on spinal cord injury, where we established a new model. And my next step will be to be interested in glioblastoma. I joined the group. I was hired by a very strong university who has supercomputer with the idea to putting up something very updating. Russia is investing a lot in science, not like Italy, and is a friend of your country. So this is good. I'm for a united world. We don't live this a particularly happy period now, but I hope for the best for the future, and I really encourage you to try best to, because your skillness is really unique, and maybe you can be very helpful not only for the poor South Americans who get training wherever. I used to work a couple of years in Cuba, so I know them. But you could do even something very good with high-rank Russians, who I guess will be very happy to interact with you.
Yes, thank you, Aldo. So for my tremor, I generally what I do is, you asked me this, so I have two Fortis Tremano hand rests. These are hydraulic hand rests which can literally support all my arm, both sides. So I can move it anywhere I want. And my chair is adjusted in such a way that I am sitting to read a newspaper. So ergonomically, I am very, very, first thing first I do in my theater is that I'm extremely comfortable. And I also do short stints. I don't go about doing the craniotomy, doing the closure, doing everything. So I come in. So today, the ENT is doing the skull base drilling, and I'll go only for the clipping part of it. So that also, that is a short phase, so that I don't have fatigue coming in. So that's one thing. Other things are I exercise regularly, and I don't take tea or coffee, and I meditate. And plus, we have something going on with a special forces soldier who had this may be interesting to you. We have a system. It's called the biofeedback system. So we connect. We take values from plethysmography, EtCO2, ABG, I mean, not ABG, in fact, it's a gas analysis that these guys have done. So they connect to your earlobe, they connect to your pulse, and they see whether you're panicking, you are in a state of panic, your tone is okay or not when you're doing certain procedures. And they can give a feedback saying that, okay, you are panicking now, or your tone is high, or you're going to go into panic and things like that. It is used for many years in elite athletes. It was never used for surgeons. So we have started a training program for surgeons to drill first on boiled eggs and then on raw eggs, and then also do microvascular anastomosis, where we are pushing them. So we maybe shake the table, we put different problems into them, and then we see the biofeedback, how they respond.
Listen, sorry for interrupting you. This seems extremely innovating and extremely interesting. I really encourage you to write a paper on that. Maybe I can help you on that, because it's a message which is extremely important. You know that neurosurgeon must compete with alternative forms of therapy. There is a very interesting new technology on aneurysm cure. I mean, the web technology really seems to give away from the neurosurgical community the handness and the responsibility for aneurysm. So people like you who can really see the aneurysm whenever with that magnification which is needed to do a precise job, can really spread apart a message which is very important for the new generation. So really encourage you to write a paper on what simply you told me, because I didn't know that. In my past career, I tried to do something similar, not so sophisticated. Try to understand that I work in countries which didn't have the financial facility that you have, I understand. But meaning the idea was the same, to make a regular self-checking in order to decrease the stress and have the stress not influence your surgical action. What you told me, it's once again extremely new and extremely interesting. I do encourage you in writing a paper on that, and even making an algorithm to be utilized in surgical, in the subspecialty schools, as a matter of fact, to identify who is keen for surgery, who is not. I saw a lot of people who were absolutely not keen for surgery, who were not stopped until it was too late. And this is something we had to start to think about. Maybe some son of papi will not be happy, but there is no way to allow some son of papi to kill people because his father was a good surgeon. No, this bad heritage should be stopped straight away. I'm proud of saying that all my kids will not be doctors, so I have no this risk.
Aldo, I'll take your number from John. And,
absolutely, please call me. I will be very happy. And consider that now in Russia is 1:30. So just to remind, what time is it now? Thank you.
Yeah.
Stay in touch. I will be extremely happy.
Sure.
Yes,
Thank you.
yes, Aldo, we look forward to hearing from you about spinal cord injuries and glioblastoma. And we're glad you found this group.
Let me speak, since I have to respect the hierarchy with my boss, and certainly I will be very happy to ask even a couple of people of my group to interact. The model we are using for spinal cord injury is brand new, is a controlled cryo injury on half of the spinal cord in a rat, and is very, very well studied and developed. Unfortunately, we already wrote 10 paper, but we have no citation. But maybe we're not bad. We are bad advertiser of ourselves, and that's a logical that is being here implemented in Russia, which is very bad. I think that Russia should be accepted as an open country to science, and Russia should accept the idea that science is an international club with no barriers. I am trying to break this bad, this bad concept.
Well, we have it at Neurosurgical TV.
Thank you. Thank you. Let me speak with my director, and a couple of days I'll call you to say that we are ready to do a little show on our model. Yes.
Great. Okay,
Hello,
very
John,
good.
can you hear me?
Go ahead, go ahead.
Okay, great. I think we should go ahead with the other questions. Um, Professor Ipe, this is Dr. Keith. First and foremost, we'd like to thank you and Professor Sufyanov for accepting to be our guest presenters. Before you, I'm sure, unfortunately you can't just see the number of residents and young neurosurgeons. We also have Professor Chikoya in our midst, listening to your presentations, both yours and Professor Albert Sufyanov. And we're quite humbled and enlightened with your presentations. From the residents
на
here
онлайн-конференцию 10 минут вам призвоню. Спасибо.
from the residents here, particularly in Africa and Asia, we're trying to wonder how we could, how they could come for fellowships, observerships. I'm sure they would they'll be interested to hear from opportunities from you, from Professor Sufyanov. Thank you, sir. If you could give an insight.
You want to describe, Mike, what's available? Oh, I guess I fell off. Okay, well, okay, go ahead. You have Dr.
Я дома вас
Katambo.
жду.
Dr. Katambo, you have anything else to say? I think I dropped off.
Okay.
Okay, well, I guess we'll move.
Yes.
Yeah, we're gonna move on. We're gonna move on to the next webcast. We have Dr. Moanangi, fourth-year resident from Zambia, is going to present on anatomy of the sella and parasite region. Okay, welcome, Doc. It's all yours.
Okay, thank you. My screen.
Are you ready, Doc?
Yes, yes.
Okay, it's all yours.
Okay.
Okay, you need to screen share first.
Yes, I am.
Okay.
Just have to enable editing. I'm sorry. Yes. Okay.
Okay, you still with us here, Doc?
Yes, I am. I'm trying
Okay.
to. Where's that?
There you go. You're on your way, Dr. Okay. Okay, very good. You're all set.
Okay. Time is it? Good afternoon, everyone. My name is Dr. Moane. I'm a fourth-year resident here at the UTH, and my presentation is the anatomy of the sella and the paracellar region. So the contents of my presentation are, I'm going to look at the sella region. I'm going to discuss the sella turcica, the sphenoid bone, the sphenoid sinus, as well as other areas, and the pituitary gland. And then I'll briefly look into the paracellar region, and then I'll discuss disease processes related to these areas. So basically, because we're looking into the sella, the most important structure that we're considering is the pituitary. So the pituitary lives in the skull base, So basically you have the anterior, the central, and the posterior skull base. And you have the temporal bones, which are considered the lateral skull base. So basically for our presentation and for the purposes of this discussion, I'm focusing on the sphenoid bone, which is a very complicated bone, and it is centrally located. So you can see, I don't know if it's big enough, you can see the sphenoid bone, you can see the pituitary, you can see the cavernous sinus in yellow, you can see the optic chiasm in green. And then you can see on the other side, cavernous sinus, and then you can see the pituitary as well as the sphenoid sinus. So the sphenoid bone is, as I've said, very complicated. It has many foramina. It's got cranial nerves coming out. And this is where the sella turcica is located. And this is where the pituitary gland lives or is housed. So when you're looking at the sphenoid bone, it resembles a bat with the wings of the bat outstretched. And it's composed of a central body. We've got the paired greater and lesser wings, and then we've got the two pterygoid processes. You've also got the anterior clinoid processes, which are located at the medial end of the lesser wings, and the middle clinoid processes, which are lateral to the tuberculum sella, as well as the posterior clinoid processes, which are the superlateral margin of the dorsum sellae. So the dorsum sellae is continuous with the clivus, and the upper part of the clivus is formed by the sphenoid bone, and the lower part by the occipital bone. So we've got the body of the sphenoid. There's a lot there. I'm not going to go into that. Then moving on to the sella turcica. So the name sella turcica comes from the it was named after the Turkish saddle, and it's different from the Western saddle. And the Turkish saddle, as you can see in the right-hand corner, is meant for comfort, if you want to compare the saddles. And it's what it has a very deep area, as you can see here. So the sella turcica is where the pituitary is housed. So it's located on the depression of the sphenoid bone. And the indentation, as I said, is where the pituitary is. So a little more detail on the sella turcica. We've said what it contains, and this is just a bony demonstration of the components of the sella turcica. So in terms of the next area is the sphenoid sinus. And these are two large irregular cavities within the sphenoid bone. And they're located posteriorly in the upper part of the nasal cavity. So each sphenoid sinus opens into the corresponding sphenoethmoidal recess via an aperture high on the anterior wall of the sinus. The sphenoid ostium is usually medial to the superior turbinate. And in terms of dimensions, we have an adult sphenoid with a height of 2 centimeters with a transverse breadth of about 1.8 centimeters, anterior posteriorly depth of 2.1 centimeters. So these are important things in terms of when you are in this area surgically, got to know these dimensions. In terms of the types of the sphenoid sinuses, this is important. There can be 3 main types. So the most common type is the sella, which is C. And here it's well pneumatized. So in terms of operatively, this is easier to access perhaps the pituitary gland via the transsphenoidal. However, not everybody, even though this is the most common type, some people may have the conchal type or the precellar type. So with the conchal type, what happens is that most of it is, it's not well pneumatized and more of it is bone. So if you don't successfully assess this, you might run into problems when you are trying to do transsphenoidal surgery. So it's very important. We've gone into the operative techniques and we've seen some amazing things, neurosurgery and stuff like that, but it's always about starting with the anatomy. It's always starting with the imaging, and it's also understanding that there's a lot of variation in this sphenoid area. So you have to take that into consideration when you're planning for surgery. So this is just another diagram showing the same thing about the different types of sphenoid sinus types. As I said, the stellar type is the most common with the most pneumatization, with the conchal type, the least type. Moving on to the diaphragmatic sella. So this is a small circular horizontal sheet of dura mater. So this forms the roof of the sella turcica, and it covers the pituitary gland. The infundibulum, which is also known as the pituitary stalk, passes into the pituitary fossa through a central opening in the diaphragm. So as well, there's variations from person to person with the size of the opening. And a deficiency of the diaphragmatic sella may lead to the formation of the empty sella. So going into the pituitary gland. So basically, this is, it's a reddish gray oval body, about 12 millimeters transversely and 8 millimeters anteposteriorly diameter, with an average weight about 500 milligrams in an adult. Its location, it's continuous with the infundibulum or the pituitary stalk. It's a hollow conical inferior process from the tuber ciliarium of the hypothalamus. And as we've said, it's within the pituitary fossa of the sphenoid bone, where it's covered superiorly by the diaphragmatic sella of the dura mater. All these things are important in terms of when you have a pathology, which we'll explore as we go on with the presentation. So this is just another diagram, and it's just about the way in which the pituitary is divided. We've got the adenohypophysis and we've got the posterior adenohypophysis. So imaging is important. So often, so here we can see we've got a higher signal for the neurohypophysis, and we've got certain areas, we've got the optic chiasm in red, and you can see the mammillary body there in green. So in terms of understanding the anatomy, I felt that it would be best to understand certain pathologies. So by understanding the certain pathologies, we can see how the anatomy is affected, and sometimes we can consider the kind of surgical considerations when planning for surgery. So the masses that occur in the sella, the most common mass is the pituitary adenoma, and this is a benign tumor which arises in the anterior part of the pituitary. So mostly it grows in the suprasellar, which means it grows upward. However, sometimes the pituitary can grow laterally, and when it does this, it invades the cavernous sinus. So here we've got, so when you're imaging, when you are assessing the pituitary gland, you've got to try and establish if the tumor is within the pituitary gland, or as in this case, where we've got a large invasive macroadenoma. So as you can see in the sagittal view, you can see we can't find really the normal pituitary gland. So this is a large invasive pituitary macroadenoma. So pituitary adenomas are very common. They do represent 10% of intracranial neoplasms. So they can be divided into two types, the secretory and the non-secretory type. And the secretory type makes up about 50%. And obviously these patients present with sometimes growth hormone secretion, thyroid stimulating hormone. So they have hormonal imbalances, and sometimes they present with these symptomology. So in terms of the differences between a macroadenoma and a microadenoma and a macroadenoma. So microadenoma is defined as less than 1 centimeter. And basically because it's so small, your intention here is to try and detect it. And the problem with this, because they're so small, they'll tend to present with endocrine imbalances. So in here, you won't be able to really see it. As you can see in this diagram with the red area, they're very, very small, as opposed to the macroadenoma, where the classification is that it's more than 1 centimeter. And here, the intention is about understanding how it expands and where it expands to. Is it going to expand in the suprasellar extension, or is it expanding into the cavernous sinus? This also presents with different symptoms. So if it was to extend upward into the suprasellar extension, it would then compress the optic chiasm, and then you have the bitemporal hemiplegia. And if it was to extend into the cavernous invasion, you may have ophthalmoplegia because of the compression of the cranial nerves in that area. So this is an example of a microadenoma. We have a patient who is a 38-year-old female who has Cushing syndrome. So you can see a very small lesion with the red arrow. So this patient presented with a hormonal disturbance, yes, you can see the lesion here. And this was a ACTH secreting adenoma. And because of the size of it, it was very difficult to locate. So it was the case of doing the hormonal test and then being able to understand where the problem was. So you were looking at the signal characteristics as well, the patient. So we have the pituitary macroadenoma, as we said, that is more than 1 centimeter. So here it has the characteristic waist, the cinching of the waist, or the dumbbell, or the snowman appearance. This is because of the dural covering as it grows up into the suprasellar space through that diaphragmatic cella. So as I said, it's normally snatched. So these types, you may have a hemorrhage or a cyst, and you may have also, because it may grow, you may have still invasion of the cavernous sinus. So here you can see that the macroadenoma is growing out into the suprasellar region, and it's compressing the optic chiasm, and these patients will have visual field defects, as I said, bitemporal hemiplegia. Sometimes what happens is that if it grows too big, the macroadenoma, it may outstrip the blood supply. And you can see in the diagram on the right, on the left, where the blood supply, this kind of cystic area as well. Moving on. You might also have cavernous, as I've stated, we have cavernous sinus invasion. So it's important when we have a pituitary macroadenoma to understand, to be able to assess for like the surgeon, you need to understand if the internal carotid artery has been encased or not. So the radiologists have developed a criteria to see and to be able to assess if it has been encased or not. So basically what they've done is that so they've drawn 3 lines at the bottom here. First of all, you have to assess the level of encasement. So the way you do that is that you draw a line which is medial, median, and lateral. You can see the diagram in the middle. So if the pituitary adenoma extends beyond the red line, the assessment there is that there's encasement. So this is important for the surgeon to understand this in preoperative planning. Another thing that can happen is pituitary apoplexy. So this is obviously an acute event where you have a sudden hemorrhage due to a pituitary macroadenoma. So the patient will present with acute visual changes, headaches, and vomiting. So in the diagram here, you see the lower one where you can just see the macroadenoma, just the sheer size of it. And then in the diagram above, you can see that the intensity, this is not, it's a hemorrhage. It's not like, you can tell that the fact that it's hyperdense, it's a hemorrhage. So this is an example of pituitary apoplexy. You can also have a very, very large pituitary macroadenoma. And you can see in this instance, it's invasive and it's just extends into over the cellar floor, and it extends in the suprasellar area. And this is important to understand as well, because this will affect your approach. In something of this size, you would not maybe, you wouldn't maybe do maybe a transsphenoidal, maybe you would consider a 2-step approach, or maybe you consider another approach because of the sheer size of the tumor. The other thing to consider, which is the Rathke cleft cyst, which is a common neoplastic remnant of the Rathke's pouch, and it can be sellar or suprasellar, and it's typically midline, and it's something that you need to be able to recognize, because you could often mistake it for a pituitary. But if you look at it properly and you keep following it, you can see that it's more central and characteristically different from the pituitary, which doesn't take up contrast like that. So moving on, we've spoken about some of these suprasellar. We've spoken about the microadenoma, but I think we'll touch on the craniopharyngioma. So the suprasellar structures give rise to different masses, and they can arise because of these structures here, from these structures here. So there's the differentiation of the types of suprasellar masses by the age. So in pediatric patients, you will find that you have craniopharyngiomas, you have the hypothalamic hematomas, as opposed to in adults, we have the pituitary macroadenomas, you have the meningiomas, and sometimes you may have the aneurysms. So just briefly on the craniopharyngioma, here you can see, yes, it's also, it's epithelial neoplasm of the Raftery's pouch. It has bimodal incidence with age groups from 5 to 14, with as well as 50 to 74. It's histologically benign, but the problem with the craniopharyngioma is that at times it's very clinically aggressive. So what it does is that it ends up causing compressive symptoms, and it's very difficult to completely resect because of the fact that it tends to adhere to the structure surrounding it. We know that characteristically you have cysts and you have calcification. So you can see a representation here of a craniopharyngioma. So in terms of gliomas, so you can have gliomas as well in the stellar region. So here you have a glioma at the chiasm. So the difference between this one, the pediatric one, as opposed to the adults, which I'll show. This one is not, excuse me, is not contrast enhancing. And the prognosis of this one is slightly better as opposed to the adults, where oftentimes this is a glioma, a GBM. And you can see the enhancing lesion. So another presentation that is seen is that of, in the pediatric population, is the hypothalamic hamartoma. And it's also known as the tuber cinereum, which is a non-neoplastic heterotopia. And you can see here, there's an absence of enhancement. And this is an interesting presentation because the patient presents with the precocious puberty and or gelastic seizures. This is where the patient has those uncontrollable laughing fits. So we also have an ectopic neurohypothesis. So here you can see there's an absence of the posterior pituitary bright spot. And sometimes this is congenital, but sometimes this can actually occur in trauma if there's kind of shearing or kind of like a shearing force. That's what they've said. So mostly it's congenital, but there has been instances where we've seen this in shearing trauma. So you can see the absence of the posterior pituitary, which is the bright spot there. So parastellar masses. So we've spoken about, obviously, the pituitary microadenoma comes up again. We'll speak about a few of these here, the schwannoma and the aneurysms. So in terms of the parastellar masses, the pituitary adenoma growing into the cavernous sinus, that's laterally, is the most common parastellar mass, but however, there are others. So this is a very important for neurosurgeons. We had a lecturer the other day who said it was important for us to understand our imaging, because as much as we can have a report, we are the ones who are going to operate. So you need to be able to defend and understand what you're going to do. So this is very interesting in the sense that you see this image and you could think, oh, perhaps what we're dealing with here is, you see that there's an image here, and you could think this is maybe a space-occupying lesion. So you think, oh, it's in the stellar region. Oh, maybe it's a meningioma. Maybe it's a pituitary adenoma. Maybe it's a craniopharyngioma. But it's always very, very important when you're in this region to always consider and to rule out an aneurysm. Because the problem with an aneurysm in this region is that perhaps you go in transvenirally and you're in there and you rupture the border or maybe the covering of the aneurysm, and then you bleed. And once you bleed in such a tight space, you're not going to be able to control it, and you'll probably lose the patient. So this is very important to be able to establish if you're dealing with an aneurysm or not. So here is a diagram, an image. So here, when you look at it, we see in the left-hand side, you see, first of all, you see a right paracellum mass, which is enhancing. And then you think, oh, maybe that could be a pituitary microadenoma. Maybe it's growing into the suprasellar, maybe it's encasing the anterior carotid artery. So then you do a T2, and with the T2, you can see CSF is white. But what you note is that the space-occupying lesion is very, very black. It's very, very black. So black indicates that there's very flat, very fast blood flow. So in this instance, when you see something like this, you see a T1 and then you see a T2 like that, with this very, very black imaging, you do an MRA. And in this instance, when they did an MRA, they found this large petrous ICA aneurysm. So very, very important, very interesting vascular. So here it is again. So you can see the steps. You see the T1, T2, and then the MRA. And then they did reconstruction. So you can see the aneurysm here as well. So have a high index of suspicion for aneurysms. Always rule them out. So here's another one. Sometimes the internal carotid arteries can live in the cellar. So you also have to be aware of that when you're going endoscopically. So we have the paracellum meningioma. This is a very common brain tumor. And this one originates from the medial sphenoid wing, dura. And this one often has, because you can see that it goes laterally, it has cavernous sinus involvement. So there may be engulfment and a narrowing and encasement of the internal carotid artery. So just to see more images, we've got the schwannoma, where you've got the cranial nerve 5 schwannoma, which encases the trigeminal, which is the most common. And you can see just the schwannoma here. Additionally, you've got the cranial nerve 3, where this one is involved. Okay. So we also have the chordoma, which is typically centrally located along the dorsal clivus, and it's lobular and it's got minimum enhancement. So basically, I just wanted us to understand how important imaging was, and in terms of planning, because you start from the anatomy, you do the imaging, you plan your surgery. So that's where you should start, and you should be thorough enough to know what to expect. And I think that determines your success. So at this point, if there's no questions, or if there are any questions, I'm available to answer them, or if there are any additions.
Okay, very good. Thank you very much for taking the time. Let me get you off the screen there. Okay, any comments or questions to share from the audience? I don't know if we can get a screenshot of the audience.
A screenshot of the audience?
It's a pretty ruly looking group.
I can do that.
Okay, let's have a screenshot of the auditorium.
Okay.
And I'll tell you what my ambitions after I see it.
Okay.
Okay,
Okay,
you,
Okay,
can anybody put their camera on or come into the webcast? It's no big deal. It's no big deal if you can't.
I'll do it this way. I'll do it this way.
Okay, it's no big deal. If we can get it, fine. If not, that's fine.
I'll do it here.
We kind of use the basic setup of a laptop in front of the auditorium. I just want to show the audience that it's easy to televise from Africa. Or just use no special camera, just a laptop in front of the conference room. Okay, go ahead. Okay, someone has
I
a hand
raised my
raised.
hand, so if you can make me a thing, I'll share the picture with you.
Oh, okay. So you're not on the webcast now. Okay, hold on. Okay. Okay, you're promoted to the panel.
Okay, join as a panelist. Okay.
You should be able to screen share there.
Okay, so here goes. Camera on. Oops, that's me.
Okay.
Where do I turn it the other side?
Yeah, you can just basically turn it on, then just turn the laptop around. You're not trying to screen share at all.
I wanted to find out from the audience, the participants.
Oh, okay, there you go.
Question.
Okay, let me pin it. Okay, there we go.
From the participants
Okay,
online.
very good. Very good. Now, the next meeting, I want to see that auditorium full. And I'll tell you why. Because this is a big talk for your community. And I think we need to have neurosurgery nurses there. We need to have neurosurgery nurses from other hospitals there. People from other hospitals in the neuro section should be in this auditorium. This is a big talk to have people like Ip Cherian, a well-known neurosurgery educator, and Albert Sufinov from Russia. These are really good speakers. So we want to bring people like that to you and to the whole community, not just the neurosurgical residents. Of course, we welcome them. So, okay, very good. We got to look. Dr. Moang, we're going to take a break before Keith gives his last talk.
So we're going to have a break right now, some 5-10 minutes, and then we'll continue, proceed.
Okay, you want to wait, Keith?
Yes, we'll wait. We'll have a small break.
Okay. Keith is giving a talk on transfemoral nasal approach for pituitary adenomas. We'll see you in 5 or 10 minutes.
Okay.
Okay?
Yes.
I'm going to put the screen on. If we are prepared. This ain't no dog and pony show. Okay, there we go. Starting soon. 10 minutes. Back in 10 minutes. Okay, Keith, well, I think we're about ready. Hello, are you there, Keith? There's chanting from the people outside the window. Restart, restart. Hello, Keith, are you there? Okay, we're about ready to start. We're waiting for Keith, are you back? Um, can someone get Keith, please? I have another conference to do, so we have to finish with this one up. Okay, you ready to? Okay. We ready to start? Hello? Okay, we need to get off the screen because I need to introduce you. Okay, you need to get off the screen so I can introduce the next speaker.
John, can you hear us?
Yeah, Keith, you need to put the camera on so we can meet your face. You can see your face.
Okay. The presentation, can you see it?
No, I want to see your face first. I want to introduce you. Can you put your face on the camera, please? This is a people platform, a facial.
No, you can see,
Yeah.
John, my face is on the presentation.
Oh, it is. Okay, maybe you're on a different
Yeah.
screen. I'm sorry. Let me look. Let me look here. Which screen you want? I don't see your face.
On
Let me see.
Katambo.
You're on the panel? I don't see you in the panel. Keith,
Uh,
can you raise your hand, please? I don't see it in the panel.
Okay,
Okay, you can go ahead and start. Okay, go ahead. Okay, now let's try and get it on full screen. Okay? So try to figure out how to get it on full screen. Okay? Just, yeah, play around with it.
can you see it now?
No, not full screen yet. You'll get it. There, perfect, perfect. You got it.
Okay. Yeah, okay. Are you able to hear me?
Yeah, we got it. We got it, Keith. Perfect.
Okay.
Just introduce yourself and the topic and away you go.
Okay. Good, good afternoon. Good morning, good evening, participants. Thank you for joining us for the Scout-based masterclass held in Lusaka, Zambia. We thank the various speakers, local and international. So neurosurgery in Zambia is pretty young, so we're trying to get the education and teaching and learning for the young neurosurgeons that are coming up. And hence we are starting a series of masterclasses that we have held quarterly. So today's presentations will be on a skull-based topic, which is endoscopic transnasal transphenoidal approach for pituitary adenomas. So I would like to thank my professors and mentors, particularly those in Europe, Professor Albert Sufyanov, Professor Aipcherian, Professor Vindoch. They've been instrumental in my learning process, particularly for endoscopic techniques for pituitary adenomas, craniopharyngiomas, chordomas, and the like. So it's great to have learned under these great mentors, and also like to thank professors here in Zambia who have helped me, Professor Chikoya, Professor Sichizia as well. So the endoscopic transnasal transphenoidal approach over the years has been modified, refined by many surgeons as a workhorse for corridor 2 lesions in the anterior cranial base, the sella, the paracella, and even as far as the medial cranial fossa. Via this corridor, you can have at least a 3D view of lesions, which you cannot have if you use the transcranial route. So slowly, neurosurgeons are shifting from the transcranial route and going for transnasal endoscopic transphenoidal route for these lesions, these complex lesions. So particularly for this presentation, we are will be studying and presenting, lecturing on the transphenoidal route for pituitary adenomas. These lesions substitutes about 25% of intracranial neoplasms. And they're usually classified by size or indeed by activity. By size, they can be classified as microadenomas or indeed giant adenomas, pituitary microadenomas for those which are less than 10 millimeters. For the activity, they can be divided as those which are functional and non-functional. The non-functional ones are the ones which secrete cortisol in excess amounts or indeed growth hormones or prolactin. So the non-functional pituitary adenomas, for those set of adenomas, we usually intervene using the transphenoidal approach if at all they exceed a particular amount of diameter or size. If at all they are less than 5 millimeters, it's prudent to monitor these patients, and especially if they do not have any clinical manifestations. If at all these lesions exceed 10 millimeters and above, they're classified as macroadenomas. And still, if at all they have any clinical manifestations, then we decide to go for surgery. Usually the clinical manifestations that warrant surgery are visual defects and excessive headaches. For prolactinomas, these adenomas usually are pretty, over the years, they have been studied to have pretty good results with medication. However, if at all clinical manifestations start, then we resort to surgery, particularly if at all we have visual decline. This is because even after, if a patient has got a pituitary adenoma causing vision decline, post-surgery, the likelihood for them to be reversed is quite slim. So a prolactinoma, a patient would do well on dopamine agonists, particularly bromocriptine or cabergoline. However, if at all we have mass effects causing neurological deficits, it is prudent and an indication for surgery. So is it so for patients with excessive growth hormone production. These patients do well on medication. However, the first line of treatment, especially if at all they are exhibiting symptoms, acromegaly, you would want to give them an option of surgery. Some of the clinical manifestations post-surgery are irreversible. For patients with SATH, adenocorticotropic hormone secreting adenomas, of course, it's prudent for them to pass through endocrinological assessment prior subjecting them for transphenoidal surgery. So all these patients have got indications. At the center, at this center, Minnesota Medical Center, we have had over a period of 4 months, we've had approximately 14 pituitary adenomas operated from December 2023, April 24. We've had 9 giant adenomas, 4 prolactinomas, and 1 acromegaly. The number of patients operated is pretty small, only owing to the fact that we just started operating on these patients. The indications for surgery on these patients were mostly headaches, blindness, bitemporal heminopsia, that is visual deficits, with a combination of hormonal disturbance, increased intracranial pressure, owing to hydrocephalus, and in some instances, cognitive decline. These are some of the examples of pituitary adenomas that we have operated at Minnesota Medical Center. These are These are giant adenomas with a size greater than 40 millimeters, causing considerably mass effect. These patients came in with headaches, some vision decline, and others hormonal instability. This is an example of a female 28 with acromegaly who was operated, case of a giant pituitary adenoma, which is protruding through the sphenoid sinus. This is another interesting case that was operated in the second trimester, a female 31 of an adenoma in pregnancy, G2 para 1. So how is it supposed to be done? Of course, the patient comfortability for the surgeon is quite vital, and the assistant surgeon. The patient has to be placed in supine position, neutral position, the degree of the head turned 15 to 30 degrees, lateral tilt to the surgeon. As you can see on the slide, the hand of the surgeon, because of the duration of the procedure, has to be adequate so that the amount of stress going to the hands and the both left and right hand shouldn't be too much for the duration of the procedure, and also be as comfortable for the assistant. The different types of approaches through the nose. You can have the mononostril approach, binostril, and also 1.5 approach. The mononostril approach we have done the mononostril approach, particularly for those which are not exceeding 20 millimeters, owing to the fact that with the mononostril approach, we have a bit, the degree of freedom through the nostril is quite less compared to the binostril approach. However, the amount of trauma during the binostril approach is quite significant. However, there are also pros and cons using the binostril approach to the mononostril approach. We haven't used the 1.5 approach technique. We're yet to use it, but as of yet, we're particularly using the mononostril or the binostril technique. The ability to resect will depend on the visibility of the surgeon to see the lesion, particularly the use of different angles of the endoscope, the 0 degree and the 30 degree. All give different views of the lesion, all have their own pros and cons, but nonetheless, the ability of a surgeon to use a 0 degree, 30 degree, a 45 degree, and other forms of degree gives them the flexibility within the cavity, especially when you're resecting the tumor, especially for giant adenomas, which affect the plenum or indeed the third ventricle, within go down. So how is it done? So when I was making the presentation, I was making it for beginners' purposes. Of course, there are many other ways of doing it, but the easiest way for establishing having access to the nasal os within the nasal phase of the transnasal approach is to understand the anatomy pretty well. So as you enter through the nostril, the first things that you might notice is the superior turbinate, the medial turbinate, the inferior turbinate, the nasal septum. The easiest approach is to go through the lower aspect of the nostril, approaching the Juana, and slide the endoscope, particularly 1 to 1.5 centimeters above the Juana, to visualize the nasal os. Only when you begin to have more cases and you're pretty used to the transnasal endoscopic approach, then you can start diving in to go straight to the nasal os. So the easiest way of identifying the nasal os is to get your anatomy of the boundaries identified pretty well in advance. Of course, you have to deviate the turbinates medially to have enough access to the nasal os. So then the medial turbinate, the spinal ethmoid recess, medially and inferiorly to the superior turbinate. That's where you can identify your nasal os. If that doesn't work, then you can just go straight to the corner, 1 or 2 centimeters, 1 to 1.5 centimeters above, you can find your nasal os. If at all it's not there or it's blinded, you can use your FIA or your pen field to just tap on the anterior aspect of the sphenoid bone. You perforate the nasal os. Important is in the nasal phase is preparation for closure of the defect post dissection or resection of the adenoma. Authors have used various methods. One of the methods that we use here in Soko is the Haddad-Bagastari flap, and that is identifying this. It's a pediculated flap, which is bounded by the sphenoid os and the corner. In the middle, as it's pediculated, needs to be the sphenopalatine artery has to be preserved so that it can be vascularized. As you can identify, this is a cadaveric view that we did here. Identify the sphenoid os on your left, the sphenoid os pediculated flap. As mentioned earlier, the first step is to identify your anatomy. The first step is to identify the anatomy. Once you identify your sphenoid os and make your pediculated flap, then you can go to the next phase. Is breaching the sphenoid os and identify the left side of the sphenoid os such that you can visualize both, and also the vomer in the middle. So as you can see on the on this slide, a beautiful view, or an owl's view of the vomer and the sphenoid os. And this is after you identify the right, then you can breach the other contralateral side, so you can have both in good sight. The sphenoid stage is where you identify the bony anatomy. Very crucial, especially in giant adenomas. You'd want to expand your boundaries of each from each side up. More appropriately from orbit to orbit. Identify your optic carotid recess, your optic prominences, the dura of your sella, the clivus, and also the clivus prominences, also your carotid prominences. After you open up the bony work, this is what you'll be faced with: the pituitary gland, the ICA on each side. Laterally, though, in case you're going to do a transcavernous approach to lesions affecting adenomas affecting the cavernous sinus, you will need to expand it even further from orbit to orbit. This is an interoperative view of the amount of bony work that needs to be exposed in especially giant adenomas. From orbit to orbit, passing through the carotid gives you enough approach for large adenomas to collapse. The dural opening has to be such that the entire base is opened, and also the top up exposed, exposing as much as the plenum. This aids the pituitary adenomas, especially giant ones, to collapse easily. So closure of these lesions can be done in different ways. There's a type, there's the different types where you use autologous material like fat, or indeed you can use fat and also artificial duras. If you do not have artificial duras, you can use other layers where you can use Mogistan or indeed Surgicel to enhance the closure of the defect post-operatively. We haven't used the combined Hadedas plus casket flap. Here we have used mostly a Hadedas flap, a multi-layer flap, and also a multi-layer closure, and also a fat closure. So this is in conclusion, would want to present a case of a female 35 with headaches and reduced vision acuity, reduced peripheral vision, and amenorrhea for more than 10 years, and an eventful productive life. This patient has had waited for surgery for long periods, for years, until she came to Mainasoko. On presentation, her prolactin levels were at 747. Other panels were normal. So we operated her via a transsphenoidal approach, and 3 months post-operatively, there was no residual tumor that was identified post-CT scan. And again, the series is a bit small, of 14 patients, so most patients are still coming for post-operative reviews and checkups. But in all patients, we achieved close to near total resection, and the clinical outcome is quite good. So as you can observe, the prolactin levels of the patient was 740, and till last month, the prolactin levels have reduced to 4. And as of today, the patient has started having had menstrual periods. So a take-home message: the endoscopic work has a steep learning curve. For the neurosurgeons that are starting their career, willing to engulf into endoscopic work, the learning curve is quite steep. It needs a lot of practice, a lot of dissection, a lot of studying of anatomy, and attending master classes and cadaveric workshop is very critical. So as we continue teaching and upgrading neurosurgery in Zambia, I urge you all to continue attending master classes and learning. So apart from that, you need to have a good collaboration with the endocrinological team. For us, we use the endocrinological team at UTH, and the head of department, Dr. Kamanga, and others who work in close contact, not only for the pre-operative workup, but also the post-operative workup. So you have to plan beforehand. All these things that we have studied, the anatomy that we have studied here is quite critical in planning, because there are so many deviations from one patient to another. So you need to study your radiological images very well, understand the nasal phase, the sphenoidal phase, the axilla phase, and also the repair phase, which is all important and critical for patients. And most importantly, you have to do it right the first time. You don't want patients to go in for repeat surgeries. If you do it right the first time, you have a patient like this who's very delighted, and also posted and gave us the authority to present her here. Picture of life after death. Thank you very much.
Okay, very good. Thank you very much for your time and your dedication. Let me just get you off the screen here. Hold on. So that, okay. Do we have any comments or questions from the panelists? Any of your associates have anything to say? Or just check in and say hello to introduce yourself? I don't know if Aldo's still
I
here.
think it's clear for everyone, so.
Go ahead, go ahead.
No, it's Ben, I think it's clear. So I just wanted to thank you for broadcasting this session. Tomorrow, we're going to have now the cadaveric dissection that for transnasal approach, and a few more lectures. So would advise the audiences to join in, and would be glad to have them in. So as of today, that will be all.
Very good. Now, Keith, the schedule is changing a little bit, so we'll go over that and make sure we put on the internet the correct schedule for tomorrow. And tomorrow
Yes.
starts at 9 a.m. Rather than 11 tomorrow, correct?
Yes.
Okay,
Yes.
so 9 a.m. we have approximately 3 or 4 talks, and we'll continue. And let's get some more people into that auditorium.
Okay. Thank you very much. Ben.
Okay, okay, and one thing, before we finish, okay, we're trying to include medical device makers, pharma, let them get involved in education like they've always been involved in education as long as I've been in medicine. They've sponsored conferences, they've supported a lot. So in the same vein, we're doing the same thing. And I'd like to introduce now, we're having, this is not part of the didactic. The didactic is over, okay? This is just the business part, the sponsoring part. And I'd like to introduce Raja. Raja, you there?
Hello, Mr. John.
Okay, there's Raja. Okay, can you get your picture on the screen there so we get to know you? Your face?
Hello, everyone.
Yeah, just
We
get
are
on the
Salman.
face there. Get on the screen. We don't see your face. Hold on. Let me get off my
No,
own.
my background is not that much good, Mr. John.
Oh,
So I directly go to the
oh,
videos.
oh, okay, okay. You can take over. Go ahead. It's all yours, Raja. Take over first. I guess you're going to do a demo of a product.
Hello, everyone. We are Sanma Engineers from India. We are the manufacturers of surgical operating microscope. So now I will share some of our product for you.
Okay. Okay, you make it large screen there. Yeah, just take your time. No hurry. There we go. Perfect. Do you have sound for this? Okay.
Hey, Mr. John.
Need to put the sound on. When you share the screen, there'll be an option of putting the sound on. So start screen sharing again, okay? Start screen sharing again.
Yeah.
Okay, and then, okay,
And
now
then I
when
will
you
share.
click on this share, there's an option to include the sound. Okay, click on the share. Okay, now there's an option there to share sound. Make sure to share the sound. Okay.
Cordially welcomes you all.
Perfect.
Globally fourth Asia's first surgical operating microscope from Sanma.
Perfect perceptive quality image, vivid stereoscopic three-dimensional view, endorse successful surgical results, ensures comfort usage and ownership. Apochromatic and BBAR optics, optimal microscopic view, with zoom magnification, continuous variable working distance, bright daylight illumination, ergonomic and smooth maneuverability movements, with the 6-axis electromagnetic brake system, joystick-powered optical head-fine movements, hand grip access control buttons for zoom, focus, light intensity, electromagnetic drive, and ICG filters. Featured with assistant stereo observer tube.
For the intraoperative imaging of flapplasty or bowel anastomosis vascularization, Sama Ocular offers IR 800 and Yellow 560. Sama Ocular has versatile imaging system with bundle of HD or 4K resolution and user-convenient optional storage. Thank you for the opportunity.
Okay, very good. Thank you for the demo. Okay, now the floor is open for any comments about the machine or any questions you want to ask Raja. Okay. Anybody like to comment or ask a question to Raja? I know this is new. This probably everyone's going to be a little shy.
It will be okay if at all.
Yeah, go ahead. Go ahead.
Bennett, if at all, he could just share his contacts so we could contact him later. That'd be kind.
Yeah, sure, sure. You hear that, Raja? You hear him?
Yeah, Mr. John. I will take a contact details of Mr. Tamaki. Our team will contact with him.
Okay, why don't you put it in the chat? Why don't you put your email in the chat, okay?
Yeah, just I will put my mail ID.
Yeah, put it in the chat.
Okay.
And so it can be picked up by any of the panelists.
Okay.
Hold
So-
on, he hasn't put it in the chat yet. Can you put it,
He has
your
put it in the
your
chat, so-
email in the chat, please, Raja?
Yes, he has put it already, so it's okay.
I
Okay,
think I
you got it?
already shared the things.
Okay. Thank you
I
very
will
much,
share
John.
if you want again. Yeah, thank you.
Thank you very much, John. So we have to go now.
Okay, very good. Okay, I'll let everyone go. And thanks everyone for participating, and thanks Roger for doing the demo. And we look forward
very
to
much.
Thank you,
having
Mr.
more.
John. Thank you.
Okay,
Thank you for
see you
the time.
tomorrow. See you tomorrow at 9 o'clock. 9
Thank you.
o'clock Zambia time.
Thank you,
Yes.
John. Thank you again.
Okay, Aldo, thank you.
Mhm.